Right. So
Yeah.
this case is that of a full-term 3.4 kilo infant who has gastroschisis. Baby's on room air, is stable. You're at the bedside and believe that the patient can probably tolerate a reduction and closure immediately. You go ahead and inform the family and the NICU team of your decision. And as you're just talking with the parents, you tell the family that you can either go ahead and repair it in the OR via what you call a standard suture technique with fascial closure, or you can just simply attempt closure at the bedside without sutures, utilizing the umbilical cord partially to close the defect. So as you're talking with them and you're discussing the questions and issues, which of the following is correct regarding the sutureless gastroschisis closure? A, you have to intubate them. B, by doing sutureless repair, your time to full feeding is reduced. You cannot do sutureless repair, C, if a silo has been used. D, complications are fairly similar to a standard repair. Or E, there is an increased length of stay when you do a sutureless repair.
So let's discuss while we're waiting. Who here uses a sutureless repair? Puts tape on it. 1, 2, 3. Who? 4, 5. Who does a sutured repair? Go to the operating room. Baby's born with gastroschisis, you go to the operating room.
So you have to define what you mean by sutured repair. So sutured repair, is it fascia closure, or is it you're just suturing the skin together in a purse string fashion? Because that can also be a sutured repair-ish, but really when you talk about sutured repair, you're talking about fascial closure.
Fascial closure.
Are you closing
does
that
anyone
fascia or
just
not?
close skin?
Yeah, I just close skin.
Interesting. I didn't know that. Okay, so you do that at the bedside? No.
You can do it at the bedside, or
the
you can
operating,
just take it to
okay.
the OR.
Fascial closure? Anyone go for fascial closure? 1. Okay. So it's pretty split here between B and D.
Yep. So the answers here right now on the poll, most people chose B, in which that if you do a sutureless repair, the time to full feeding would be reduced, versus D, that the complications are similar to a standard repair. And the answer is in fact that the complications are similar to standard repair. And so when we look at the sutureless repair, the whole idea of sutureless repair in the fashion that it's being done now came about, like most things in pediatric surgery, by serendipity. I think it was Tony Sandler was in Iowa at the time, and he had a baby who came with the intestines, just so much of it out, he couldn't figure out what to do. It took him a while to get everything back in. And once he got everything back in, the wound was so big, he just couldn't close it. And so he figured he'd just flop the umbilical cord over it and put a tegaderm on top of it and said, we'll come back and fight another day. And when he came back to fight in a few more days, in fact, the wound was closing. It was half the size, and then he let it go, and then it just closed up on his own. So he was quite surprised with that. And then a couple of years later, he actually reported a series of these patients. The first series had about 10 patients in it, and it was his experience from Iowa. And he reported basically he didn't need to take them to the OR. They just closed on their own. So that's how the whole idea got born. The thoughts are that, well, obviously you don't have a need for anesthesia. You can do this at the bedside. You don't need the anesthesia. You don't need to transport to the OR. Potential to reduce ventilation days if you require intubation. There's a chance to improve other outcomes as well. In fact, the data is somewhat conflicting. And so there's been multiple retrospective studies on this, which have reported that, yeah, they're way better. They eat quicker, they go home better, they don't need to go to the OR, and therefore it's probably cheaper to manage them this way too. And so it was great. But when there was a randomized study that was done, so this was a randomized study that was done about 2 or 3 years ago that was published in the Journal of American College of Surgeons by Bruzzoni and their group from Stanford. And they randomized babies at birth to either have sutureless repair which could be done with or without the silo, or to sutured repair, where they close the fascia. And what they found was kind of strange. What they found was that they took longer to eat. They had a longer hospital length of stay in some cases. And so it was conflicting data because it conflicted with all the retrospective studies and even a subsequent one, which was done with 98 patients from their partners in San Francisco at UCSF, which showed a benefit for all of those things. So I think the jury's still out as to where sutureless repair lies. The take-home message, as the slide says, is that what it's taught us, perhaps, is that the old adage that you must close the fascia for all these babies is probably not true. You can just simply do some kind of version of a skin closure, and that's okay. You leave an umbilical hernia. The data over 5 years shows that about 13% of them will need a umbilical hernia repair performed, which is higher than babies who got a fascial repair. But umbilical hernia repairs at about 4 or 5 years of age is usually a very straightforward operation.
So on that last point, I love how you phrased all this because there have been, and I'm sure Whit can attest to this, there have been a lot of papers in JPS over the last couple of years, because I know we've done a lot of reviews on them, looking at these two groups. And you said it perfectly. They all disagree with each other. The study by Robert Baird, when he was at McGill, showed everything was better about the tape closure versus, in fact, in his paper, they had a lower umbilical hernia rate, which was really surprising. But then you have the Bruzzoni study, which disagreed. I think it's time for the Midwest Pediatric Surgical Consortium to do this the right way. We need to get multiple centers together, not single center. It has to be prospectively evaluated.
So, and I think one of the things so we looked at our own data recently and found that obviously our length of stay had gone up since we'd started doing more sutureless closures. And one of the things that we think is driving it is a fear of feeding, right? Okay, the kid doesn't have a primary closure of their fascia, so we're hesitant to feed them because we don't want them to get super distended and eviscerate, right? And so that's sort of been our thoughts. We actually just recently with our NICU instituted a feeding protocol. And so we have some more objective things. If the Rapogel output is less than 20 per kilo, it comes out. If the kid is tolerating, you go up by 20 per kilo per day, and trying to see if we can push ourselves along to having normal things. I think it's really hard in these studies to know what's driving your difference in feeding or your difference in length of stay. Is it practice patterns because of our own hesitations, or is it really a difference in the patients?
It's totally, you're absolutely right. It's practice patterns. So in some of those studies, they simultaneously introduced a feeding protocol. And then they said, they introduced a feeding protocol. Mm-hmm. And so the key thing here is, when as Todd mentioned, if you're going to do a prospective trial, is to make sure you compare apples versus apples. Because there'll be a natural selection bias that, this one is easy. And is more amenable to a sutured repair, a sutureless closure. And so those are the ones that are going to have a better kind of easier, slower, quicker outcome anyway. So you have to be careful that you're not selecting out patients who are going to be better, if you will, right off the bat. So you have to make sure that you put equal emphasis on that.
So Saleem, I was interested in your figure of around 13%, 15% of patients who I think I understood eventually needed an umbilical hernia repair, as opposed to actually who had an umbilical hernia but never underwent a repair. So my question has to do with the mechanism of closure of the umbilical fascia. So I think we all think that there's some contracting mechanism that happens at birth that we don't really understand that allows the umbilical hernias to close. The teaching used to be that that didn't really happen if you had an abdominal wall defect because somehow you interrupted that contracting mechanism. So is there any more information about how or why the umbilical fascial defect actually closes in these babies who undergo the sutureless repair?
I think so. I think it's each study that mentioned it. The last one was the one from UCSF with 98 patients, which was published in JAMA Surgery, I think last year or earlier this year. And basically, they found, they're the ones who studied them for over 5 years. So they had 5 years of data, and the older ones were requiring hernia repair. 13% is what they found when they compared it to the sutured group. That was historical control. And so they didn't comment much on that. But yeah, that's an interesting thing that maybe need to be looked at. There's other studies which have shown that when you attempt a fascial closure and try to bring it all together without a silo, so an immediate repair, those patients tend to have a higher incidence of umbilical hernias or ventral hernias, whatever you want to call it, requiring repair. So,
an interesting thing, you sometimes get pushed by your peers. So I really loved closing these with the baby paralyzed. I been pushed by my peers saying, why are you still intubating these patients? No one else does that. And so now I've been pushed by my peers where I do it that way. And I still think it's cruel and unusual punishment to the kid who does not love having their bowels squished in while they're awake. I do it. I'm wondering about risk reward on that. I think my success rate's higher when I do it with them paralyzed, but I know that the recommendations are to do this with them wide awake.
So yeah, when I do mine, and I do a variation of it. Like I said, I do a suture. I suture the skin closed with a monocrystal stitch and just purse string it around the umbilicus, and I don't close the fascia. So I don't require them to be paralyzed, but they are asleep, and so they do get intubated from that standpoint. That brings to the question of whether we believe that general anesthesia in this age group, in fact, has a problem or not. And I think animal studies say yes. Animal studies say that every single general anesthetic agent in every class that has been studied, whether it's a volatile gas, whether it's an IV, whether it's ketamine or an NMDA receptor block, it doesn't matter. All of them in rat studies and mice studies and sheep studies have shown that they all cause increased apoptosis and pervasive developmental issues. When you look at humans, though, there have been now 2 or 3 very well-done trials, including the GAS trial and the PANDA study. The GAS trial now has 5-year data showing no difference in neurodevelopmental outcome in babies randomized together either spinal, their inguinal hernia repaired under spinal, or general anesthesia. Arguably, using the dumber gender, males, as their higher population and comparing them to females.
Mac?
Just to make an obvious comment that we all understand, but I'm not sure we said it out loud. You hinted at it, Saleem, and that is the heterogeneity of this population makes a huge difference in the results we're talking about now. There are some where the flap closure works easily. Little Tylenol in the bottom and shove the 1 or 2 loops back in. But then you've got these complicated cases that need a silo and need to go to the OR and need other things. So right now we have one prospective randomized trial.
Correct.
Where they didn't take into consideration the heterogeneity. All those other trials are biased by this 100%. One I can do this way, but that one is really hard. And so we just, as we go forward, we need to figure out how to sort that out. That's all.
Absolutely. One size certainly does not fit all. No, and there has to be horses for courses.
Mark Wolkan?
So I was going to say, recently, one of my fellows talked me into taking a larger defect, and we wouldn't close it with the umbilical cord all the way across, and we just spiraled it around. And even that works. I mean, it's as long as you have enough cord. So, it's interesting. I think the technique is still evolving. And, again, to Mac's point, we're not sure what patients this is going to work best in and which ones it's not. But one of the things that is a theme been, through all of these presentations this morning is that less is more. Mm-hmm. And, one of the things that, we always say, way back when this course used to be all about, how to do a thoracoscopic TEF or a lobe, and it was all about MIS. And, I'll say that minimally invasive surgery is a concept, not a technique. And, this is just taking that concept to gastroschisis. And, I do think that as we think about things, that we do a lot of things that cause more harm. And, whether it's interfering with the abdominal wall's ability to close up that umbilical hernia or not by messing with it, who knows? Maybe Saleem has the answer where you just close the skin. I don't know.
I like that,
But
actually,
it's,
yeah.
there's a lot of, I think there's a lot of questions still to be answered.
So a couple things. Tony Sandler says that I think I'm right about this. He does not even use the umbilicus anymore, the umbilical cord anymore, or you don't need it. You could just, that's not as important as we once thought. I think it just sort of sits there. So that's number one. Number two, some people will put a silo on, reduce it with the silo, and then put the tape. So even if you can't get it back in, it doesn't mean you need to immediately tape the kid. We have just, and before we get to Steve, so Maria Varela from Argentina says that they currently take them all to the operating room for a general anesthesia for fascial closure. Number one, she says they see umbilical hernias in this population.
Yes.
And she's very intrigued by this discussion and maybe she should try the other way. So, Steve.
So part of the, at UCLA, we have a UC Fetal Consortium where we actually standardize the care for gastroschisis. And all of them are attempted without general anesthesia, without intubation, even minimal narcotics. And we've, also identified antibiotic protocols, feeding protocols, and so forth. And what we found was very interesting was the fact that the length of stays did not decrease, even with this strict protocol. What we did find was the use of antibiotics, the intubation days, and the opioid use significantly decreased. Right. So one of the partners also was able to even open the defect, reduce everything back down, and still do a skin closure or sutureless closure with that. And that still works very well with great outcomes.
Just a question for you. So if you have patients with complicated gastroschisis, so
they're out the door.
Yeah.
They don't fit the pathway.
So do you close them initially, or do you take those patients to the OR and address their atresias, or
the complicated?
like if you have a patient with an atresia that you can obviously see when they show up?
We've closed them and addressed them later on.
That's what I do too.
Unless it's the only ones that we don't, it would be those that are perforated.
I think next year we should do that as a topic, because I know that you, Aaron, taught me some stuff that you do with when you have an atresia, best way to manage an atresia with gastroschisis, and we've had like 5 in the last 2 months, so it'd be an interesting thing to discuss. Any other?
There's a question from the audience related to asking about whether some of these different factors will influence what technique you use to close in terms of thickness of the peel on the intestines, and whether the baby was born via C-section or vaginal delivery.
So route of delivery usually doesn't make a difference, at least in the way I look at it. They should all be, unless there's an obstetric indication or something like that, they should probably all be delivered vaginally. I think that's pretty much the consensus from studies. So there's that. The other issue is the degree of peel. So the degree of peel was they tried to kind of quantify that using what's called the GPS, the Gastroschisis prognostic index or prognostic score. And the Canadians did that using CAPSNet, and they assigned a score based on the degree of peel, the degree of bowel distension, matting, and they gave it a score. I forget what the scoring system was on a scale of 1 to 10 or 1 to 5. And they used that as a proxy to see if that would help in kind of telling, these are really bad ones, these are really good ones. The GPS in the long run didn't seem to really matter as much. It was a good idea, but it didn't really end up mattering that much. But most of us would say that if you have one which looks really bad with very thick peel, very distended, lots of bowel loops out, then you would probably not want to consider an immediate closure. Those will all go in the silo, and you'll try to reduce them and get them done. At the end of a silo, you can always do a sutureless repair. That's fine, but you wouldn't try to do an immediate closure in that case.
So in those studies, what is the rate of conversion from sutureless technique to surgical closure, and reasons for the same? Did they discuss that?
They didn't. They did talk about how there's been a transition, like Todd mentioned, that basically everybody said this is the way we're going to do it, and people were dragged kicking in or screaming, or both, into doing it. And so they converted. In 2013, their group converted, and so they just pretty much all do it sutureless. The question when you talk about suture repair, again, is you have to talk about what you really mean by that. So if you're just using sutures to close the skin because you somehow it's too wide a defect to bring things together, versus you're actually closing the fascia. So I think at this point we've understood that there's no real big need for fascial closure in no matter what the size of these gastroschisis defects. That if you can get skin closure alone in some way, shape, or form, that's probably adequate. So they didn't mention much about that, but again, those which they're unable to close, you can always just bring the skin together.
Question from India. They want to know if matted bowel plays into your decision about what to do. For me, it doesn't. I don't.
Yeah. So if
usually
it's
matted.
really badly matted, then you can't do an immediate closure necessarily. You won't be able to push everything back in. You'll probably end up putting a silo on and using a silo to reduce. And once it's reduced, then it doesn't matter. You're right. You can do a sutureless repair at that point. It's completely fine. You can just close the skin.
Okay.
And so that, yep. So matting doesn't really matter.
Let's go to break because I think